Humans have evolved with Mycobacterium tuberculosis. There are evidences that Erythrithenun, also known as Dr. Granville's mummy, died due to tuberculosis in 600 BC. Even today, tuberculosis remains one of the most widespread and deadly infectious diseases in the world. Sick TB patients are the reservoirs of Mycobacterium tuberculosis, and very sick TB patients exhale Mycobacterium while coughing. When a healthy person inhales Mycobacterium, they are able to reach deep inside the lungs to the alveoli. Upon reaching there, the person's immune cells called macrophages become active and they quickly engulf the Mycobacterium, and often tubercles are formed in which the bacteria remain confined. Some of the macrophages, having engulfed Mycobacterium, are able to reach the nearest lymph node where the infected macrophages are taken care of with help from other immune cells. However, in unfortunate situations, the immune system is unable to get rid of the infected macrophages and the bacteria multiply within the macrophage. The bacteria then come out of the macrophage and infect other adjoining cells, ultimately making the person sick. In our country, the annual mortality to tuberculosis is extremely high. There are around 370,000 reported deaths of TB patients per year. It is almost like a train carrying 1,000 TB patients crashing daily with no survivors and never reported. This is the scenario even though it is not an untreatable disease, and theoretically, the first encounter with the disease is 100% curable. Why is TB then still such a serious health problem? We need to ponder as to why it is that in spite of such huge efforts by the state and others, not much has been achieved as far as controlling this disease is concerned. Why is it that the numbers of cases of multi-drug resistance and extensive drug resistance are on the rise? Is there something very seriously wrong with the management of the disease? Are the priorities for management of the disease improper or misplaced? To find these answers to the questions, we need to look at the complexities of the disease and its treatment very closely. There are several problems in the diagnosis of TB. The symptoms of the disease are not very different from common illnesses, and most diagnostic tests lack desired sensitivity. The problems related to the treatment of TB are even more serious. There is a standardized treatment regimen incorporating antibiotics for treating TB. The drugs for TB treatment kill the bacteria either by disrupting its cell wall synthesis or metabolism or inhibiting the RNA synthesis. In most cases, the TB bacteria reside deep inside the tissues, and it takes a very long time for TB drugs to reach there. For these drugs to be effective, they have to be taken for minimum 6 months to 1 year. In clinical situations, one of the main problems with these antibiotics is that they not only kill the Mycobacterium but are highly toxic for the patient also. It is therefore an irony that the most unaddressed situations of TB treatment are linked to undernourished patients, and the majority of the TB patients fall in this category. A patient, 18 years, male from Mungli, came on 4th April 2011 with a history of 4 months treatment from a private hospital with no improvement. Was very sick, extensive TB on chest X-ray, weight was 28.4 kgs, height 159 centimeters, BMI 11.34. Was started on 6 drug, diagnosed to have MDR TB, started on second line drugs. Developed psychosis due to the treatment, cycloserine stopped and antipsychotics given. Later also developed hearing deficit. Amikacin also stopped, is on moxiflox, clofazimine and cycloserine pyrazide. Weight now is 40.2 kgs. Long way to go. Still, his mental status is in good. A patient, 60 years, male, from village Pataita, weight 36.4 kgs, height 159 centimeters, BMI 14.4, diagnosed as Cat2 sputum positive, had received treatment from CHC Kota for 6 months, had some improvement, went back to them after 3 months and sent back again. Diagnosed with extensive TB, Cat2 started on 6 drugs for possible resistance on March 15, 2012. Started having pain in the abdomen and vomiting for 20 days, had raised liver enzymes, admitted and most TB drugs stopped, improved and TB drugs restarted, weight further dropped to 31.8 kgs, now improving slowly, some weight gained, now 33.2 kg weight, still has much pain, no jaundice but has abdomen pain. Guy Banjare, female, village Sakara Takhtpur, Bilaspur, weight on admission 39.6 kgs, height 152 centimeters. Came very sick on the March of 19th, 2012 with pulmonary tuberculosis, vomiting due to intestinal tuberculosis with gangrene and obstruction. Could not be given any TB drugs orally and thus received only injectable amikacin, ciproflox. Then required surgery to remove the gangrenous bowel, seemed like dying then, weight decreased to 34 kgs, no weight gain for the next 4 months. Slowly the intestines improved and over 7 months now her weight is 46.6 kgs, doing well. Rajapati, 42 years, male, village Sendri, Bilaspur, weight 41.9 kgs, height 162 centimeters, sputum positive, culture sensitive to all first line drugs. Started on 4 TB drugs on July 3rd, 2012, developed diarrhea that lasted 14 days as soon as treatment was started, resolved on its own. Weight decreased and very delayed response. Weight reduced every 15 days and was finally 36.5 kgs on August 2012. Had to be given blood, had to be admitted, treatment continued. Now his weight is 42.1 kg today. Only 200 grams weight gain. Hiccups continue. Ganga Gond from Takhtpur block, weight 37 kgs, height 162 cm, BMI 14.2. Received DOTS for 6 months before and had no improvement. Came after 2 months of stopping the treatment. Diagnosed as Cat2 sputum positive, started on 6 TB drugs daily here from May 18th, 2012. Suffered weight loss to become 33 kgs in July. Hemoglobin dropped from 8 to 7. Developed hematemesis after 2 months, admitted for 6 weeks. Developed pus in the pleural cavity and had an ICD for 5 weeks. Culture was sensitive to all first line drugs. Improving slowly. Weight today is 35 kgs but no fever. Lakshmi Gond, 16 years, female, Chakandi Mungle district, Bilaspur. Before she came to JSS in February, had treatment twice before 1 month at CHC Lori, had problems of vomiting, increased fever and appearance of swellings. Stopped, then for 3 months again in a private nursing home in Bilaspur and did not improve. At JSS, weight was 24.9 kgs, height 154 cm, BMI 10.9, sputum negative but culture positive, resistance to S and H, sensitive to R and E. Was started on 6 drugs including amikacin and levoflox. Started improving after 4 months. Now the weight is 28.5 kgs. On maintenance phase, delay in switching off amikacin. When I write conclusive TB diagnosis for typical 25-year-old person who weighs less than 35 kgs, I get shivers. With no exaggeration, it is almost like writing a death sentence. The person may die of TB or of drugs also, and it gives us a formidable challenge to save his life. Most unfortunately, we face such challenges quite often. These factors make treating TB very complex. Researchers suggest different reasons for this. In typical Indian conditions, it is found that about 40% of patients leave the treatment due to the drug-related problems, that is toxicity and side effects. Other reasons are migration for livelihood, which lead to discontinuity in about 30% patients. About 20% discontinue the treatment due to relief from symptoms, and about 10% do so because of work-related reasons. Discontinuation of treatment has serious consequences. Emergence of MDR being one such consequence. As the treatment of MDR is costlier and the drugs are even more toxic, chances of patients leaving the treatment in between are much higher, leading to XDR. Chances of successfully completing XDR TB treatment is very rare. This is like a vicious chain, from sensitive TB requiring tough treatment and leading to incomplete treatment and MDR. The MDR cases requiring tougher treatment leading to XDR, and finally the XDR cases requiring even tougher treatment, often turning out to be fatal. Most important aspect about TB treatment is that there are far too many cases of acquired MDR or XDR as compared to primary MDR or XDR. Growing numbers of MDR or XDR very clearly point out that the delivery system is not operating properly. There is an inherent flaw in the belief that the problem of MDR or XDR can be solved by replacing the existing antibiotics with more specialized ones. There is absolutely no doubt that there is a need to discover new drugs for TB. It is also true that better drugs for MDR or XDR are needed. But it is much more important to attack the root of the problem by finding better drugs for sensitive TB. The chain needs to be broken at the very first step. This is essential even for addressing MDR or XDR TB. The newer drugs for sensitive TB should be able to shorten the duration of treatment, should have longer stay in the body, should have longer half-life, should be able to move or diffuse quickly inside the tissue, and should be less toxic. Our primary concern should be to find better drugs to treat sensitive MTB. Also, the drugs alone cannot do it. We need a foolproof delivery system that is equipped to take into account the limitations of drugs and patients. In fact, drugs cannot be seen without the delivery system. Requirement is not just of new drugs. The attitude towards non-adherence and the defaulters has to change. It should be remembered that every patient wants to be cured. It is too simplistic to assume that non-adherence is just due to complexity of the treatment. After all, people consume food in a fairly complex manner, so there are more serious reasons for non-adherence. But this will happen only when the scientists are able to understand the problem in a broader and deeper sense, where they see mycobacterium along with the patients, and pharmaceutical companies start giving more importance to the suffering of the people than to their own benefit.